Thank you, Organising Committee, Sharish, for the invitation to join you today here in Pune. It's an honor for me to join you and to share some of my experiences with shoulder. My background is I practice in Johannesburg. I've been in practice in shoulder surgery for the past 10 years, dealing exclusively with shoulder surgery. I did a fellowship in France with Dr. Collin in Rennes, and since then I've been doing shoulder surgery. So moving on, we're going to move away from the anterior instability, and I'm going to talk to you about posterior instability and how I deal with it and how I think we should approach it. Typically, we also always think of posterior instability as associated with electrocution and epilepsy and alcohol abuse, posterior dislocations. But posterior instability also entails pathology of the labrum, not so severe dislocation, but pathology that leads to pain. It's actually very common, up to 10% in this Norwegian study. And you must always remember that posterior labrum pathology in a quarter of the cases are associated with other associated pathology in the shoulder. So when you find posterior labrum pathology, consider and make sure you don't miss anything. Why is these lesions more common? Well, it's the advent of arthroscopy and MRIs, and that helps us to delineate and identify these lesions. But we still miss them. And why do we miss them? These patients seldom have a history of dislocation. They complain of pain and decreased performance, but not necessarily instability. They've got multiple minor events that seem insignificant, and the physical examination is quite difficult. And unfortunately, MRI has also its limitations. And so in 70% of cases, MRI findings correlate with surgical findings. It's important to have a good history, listen for pain, for weakness, for decreased sporting activity and performance, a sensation of instability, not so severe an event, but a sensation, and if there's a history of trauma, inquire about the mechanism. As Leonard Funk in their study in 2012 showed, that by inquiring about how the patient sustained the injury, it could assist you in identifying what type of pathology. And in South Africa, we have a lot of rugby. So obviously, falling with a fixed arm often leads to these labrum injuries. Physical examination, there's a few ways to check for this. Posterior translation and pain with posterior translation is not very specific, but sensitive. Kim's test I find quite difficult. We have big, bulky rugby players, and so I'm not always certain whether this test is accurate in my hands. So basically, you get three pathoanatomic type of injuries: traumatic event, the patients with atraumatic events and instability, and then you have those patients with cumulative microtrauma. And I must say, in my practice, what I've also seen in the cumulative microtrauma group of patients is those gymnastic patients of mine, younger patients, keen gymnasts. They tend to develop posterior pathology with repetitive exercises. Remember, this is not a reverse Bankart, so bone loss is not very common. So the whole issue of bone loss, yes, there are in the literature cases about bone grafts posterior, but in essence, the huge majority does not involve bony issues. Dislocations are rare, but be careful for the patient with abnormal glenoid morphology, because those tend to repeat more often. And there's various variations in pathology. Purely a labrum detachment can sometimes not even be that impressive. They have often combined lesions and capsular tear, as you can see in the picture at the bottom there. And then you also can find these lesions with a labrum split. So you don't see a significant detachment of the labrum from the glenoid, but you see a split in the labrum itself. And then obviously posterior laxity of the capsule. MRI arthrogram, usually if you find some leakage of a contrast, it's an indication, but also look for associated pathologies like a sphenoglenoid cyst. This can lead you often to a labrum pathology. Obviously, a specialized radiologist can be of benefit, and be careful and be on the lookout for associated lesions, because sometimes the radiologists miss associated lesions. They just see the posterior labrum and they miss a capsule compromise or tear. So always just briefly showing you some of the scans and how they look like. You can see clearly there's a labrum tear there. And then obviously look out for sphenoglenoid cysts, as these can often also indicate. Another speaker will be discussing this in more detail. In my hands and in my opinions, and when the surgery indicated, my patients with pain. These patients have pain. They come to you with pain. They have a long-term history of injury or trauma, but they have persistent pain that don't respond. Patients with associated lesions, as we discussed, slap lesion is often also associated, and they've not responded to conservative treatment. And in those rare cases where there's a bony lesion, you probably have to consider surgery. According to the literature, the surgery is very successful with a 92% return to sport. My techniques on how I do it, I do a lateral decubitus position, and the reason for that is, no, I don't use a lateral decubitus, I use beach chair, but lateral decubitus has been shown to be a very good access. The reason for the beach chair, in my opinion, is I can address other pathology also very well with a beach chair. Portal placement is crucial, and especially the posterolateral portal I will show now, and that's for your placement of your anchor. If you're using your viewing posterior portal, you might be too parallel to the glenoid surface and therefore break out into the glenoid. Different areas where you can repair the labrum. And then here in my technique, I use an anterosuperior viewing portal just anterior to the biceps. And then when I'm finished placing that, I then have another working portal just superior to the subscap. Assessing the posterior labrum, I'm viewing from an anterior superior portal, and you can see there that the labrum is compromised here using a probe. Now, it's also important, as I mentioned, a huge percentage of these patients have associated lesions. In this patient, we can see a compromised anterior labrum. We're viewing from a posterior portal, subscap, biceps, supraspinatus. We have a heel sacs deformity. And you can also see, if you look closely, you can see there clearly a big capsular compromise leading to the posterior instability. So the capsule tears you also need to address when you consider stabilizing the posterior part of the shoulder. And also, in these lesions that are not clearly defined, you should make a very good examination, because if you miss an intrasubstance tear, you might do an arthroscopy, you don't find any pathology, but in fact you missed a very subtle instability due to a tear within the substance. It doesn't look significant, but certainly this patient on examination revealed posterior pathology, and if you can see there clearly the labrum is not completely detached as we would see in an anterior labrum tear, but is insufficient posteriorly. Just also, and I'm sure speaker coming up will discuss it, but you must be on the lookout for the sphenoglenoid cysts and try and address those also and drain them, as they can lead to neurological problems. I perform aggressive debridement posterior, and I use a curette. It's on the arthroscopy hip set. You find this curved curette, and that helps to prepare the bone so that we have good healing there. Inserting the drill. Some of the companies have different types of angle drill sleeves, but again, your angle of attack is important, not to be too parallel to the glenoid, and to make sure that you have good fixation onto the glenoid rim. I use a shuttling suture technique. This device, I'm able to also placate some capsule if I do want to do that. There's many devices on the market, but in essence, you want stable, rigid fixation. I prefer a knotted technique rather than a non-knotted technique. I shuttle the sutures, and I placate the suture and placate the labrum to the posterior glenoid rim. The results difficult due to outcome measures. Arthroscopic outcomes are significantly better than open techniques. Revision surgery, your problem is these outcomes are poor, so make sure that your first attempt at doing a repair is successful. Poor results are often due to lesions not identified, so again, do a good arthroscopic examination, the whole shoulder joint, and the patients return to sport quite successfully. In brief, rehabilitation means 6 weeks in a sling. Thank you very much.